So, hello. My name is Haifa Kathrin Al-Ali, and I am the head of the Krukenberg Cancer Center at the University Hospital of Halle in Germany. Today, I'm really delighted to be joined by Professor Jean-Jaques Kiladjian, Professor of Clinical Pharmacology at Paris Diderot University and head of the Clinical Investigation Center of the St. Louis Hospital in Paris, as well as with Professor Alessandro Vannucchi, Director of the Haematology Department at the University of Florence in Italy. Today, we would like to discuss with you how to tailor treatment in patients with myelofibrosis with a specific focus addressing anemia and thrombocytopenia. And we'll just start with the burden of myelofibrosis, as I said, with emphasis on anemia and thrombocytopenia. As we all know, the clinical manifestation in patients with myelofibrosis could vary largely between patients, in addition to the usual burden of the disease symptoms like fatigue, constitutional symptoms like night sweat, weight loss, and so on. The massive splenomegaly we have in many patients, thromboembolic events, extramedullary hematopoiesis. But we do have two other major issues we frequently see in our patients, namely anemia and thrombocytopenia. You know, anemia defined as a hemoglobin below 10 grams per deciliter is quite often seen in about one-third of our patients at the time of diagnosis, and the incidence increases with time. It is multifactorial, mainly due to ineffective erythropoiesis, but also hepcidin dysregulation, inflammation, and so on. And we know that anemia does have a big impact on the quality of life of patients with myelofibrosis. Speaking about thrombocytopenia, defined as platelets below 100, it is less frequent than anemia, but still we could see it in around 15 to 25% of our patients. Again, multifactorial, ineffective erythropoiesis, hypersplenism, and so on. And we know very well that thrombocytopenia indeed is a challenge for our treatment management, treatment decision. And again, both anemia and thrombocytopenia do have a very big impact, a negative impact, in addition to the quality of life, on survival and outcome of our patients. And indeed, we have several questions. These were pre-canvassed from the target audience. And Professor Kiladjian, I would like to start with you. What additional burden does anemia and or thrombocytopenia have on patients with myelofibrosis? And how does this impact the quality of life of your patients?
That's a very important question, and this anemia in particular and thrombocytopenia obviously have a clear impact on the quality of life of our patients. And for example, we have one study that included 155 patients from several countries, including US, UK, Germany, Italy, Spain, and Poland, in which it was asked, and in these patients, the majority, 88%, had anemia. And when we asked them what was their feeling about that, they reported 59% of the patients reported transfusion being extremely or quite a bit inconvenient, for example, because of the time spent in the clinic or the travel time and scheduling issue that affected more than 80% of the patients. In addition, they expected an improvement with less transfusion dependency, and most of them feel that it would improve their daily activity, emotional health, and social life, as well as physical activities.
Thank you very much. Yes, I think this is really a very important issue. Professor Vannucchi, what role do transfusions play in terms of supportive care for patients with myelofibrosis and anemia and with thrombocytopenia?
Well, as mentioned before, anemia is highly impacting on the quality of life of patients with myelofibrosis. And so some of them who develop transfusion dependent anemia may be highly dependent on transfusions. And the tolerance to anemia is another variable that may change from patient to patient. For example, this is an old population of patients. So some patients may have, for example, cardiac issues, and these often requires to be transfused at higher level of hemoglobin than usual than for younger patients. And so the number of transfusions a patient may have every week or in total in a month may be highly variable, but some patients may need 1 or 2 transfusions for a week. And this is, of course, needed for them to have an acceptable quality of life and, of course, to prevent complications for anemia. In case of thrombocytopenia, the issue is more complex because we know that platelet transfusions should be used in patients who have some kind of bleeding symptoms. They are difficult to be used prophylactically because platelet transfusion have a very short lifespan, and there are also issues of supply of platelet transfusions.
And maybe I just want to ask shortly, are there any challenges to the transfusion issues in Italy?
Well, actually, transfusions are necessary for these patients, but they may also bear some kind of complications because some patients may develop intolerance to transfusions over time. They become immunized against the different red cell antigens. And also, being transfusion means that the patient has to go to the blood center. Often relatives, caregivers are involved. And so this is an additional burden, additional to anemia.
And Professor Kiladjian, how is the situation in France? Do you have any particular special challenges?
Yes, of course, we have, I think, as in every country, problems for young patients, for example, that still work. They need, to stop working for a day, coming to the hospital for transfusion, etc. And for elderly patients, it's the burden of transportation to organize that and have a full day. So overall, the benefit in terms of quality of life when a patient is transfused is not so good because you have this phase where after the transfusion they may feel better, and then there's a decline in the hemoglobin level, and again the symptoms reappear. So it's quite not easy, I would say, to address the quality of life of patients with transfusion only.
Fully agree. And I think our problems are the same across Europe, wherever the patients are. Maybe the impact of survival and why it is important to initiate treatment early, particularly in patients with cytopenia. And I would like to address this question to Professor Vannucchi.
Well, we have been able in more recent years to identify a subtype of myelofibrosis that is so-called cytopenic, just to make the difference with the myeloproliferative forms of myelofibrosis. And we know that being cytopenic, the most frequent cytopenia is anemia. More than 50% of patients at diagnosis are anemic, and this may raise to almost 80% after 1 or 2 years of the disease. And we know that even moderate, not necessarily transfusion dependent, but even moderate anemia may cause a significant reduction of expected lifespan. And the same is for thrombocytopenia, that is less common. And the combination of anemia and thrombocytopenia also carries an additional risk on survival. And so this means that targeting cytopenias is really an important target for the treatment of patients with myelofibrosis.
Absolutely agree. And any thoughts, Professor Kiladjian?
No, I agree with what Professor Vannucchi just said. It is of note that anemia has always been, since the first prognostic score in myelofibrosis, the so-called Lille score many years ago, anemia was a strong predictive factor for survival, and it remained in all the subsequent scores we have until today. We have a dozen of them now, but they all include anemia, and in particular for the DIPSS, the one that assess, during the course of the disease, the prognosis of our patients. Becoming anemic is a clear change in the disease history and worsen the prognosis and reduces the life expectancy.
And I think transfusion makes it even worse, and the life expectancy of these patients is really very much reduced. And now we would like to discuss the targeted treatment strategies for myelofibrosis, particularly in patients with anemia and thrombocytopenia. As we all know, there are a lot of treatments available for a long time and new treatments to relieve transfusion dependent anemia in patients with myelofibrosis. We have the ESAs, we have steroids, splenectomy, radiotherapy of the spleen, androgens, immune modulators like thalidomide or pomalidomide, and we have the JAK inhibitors. And truly, we should not forget allogenic stem cell transplantation. Generally, for many of these old traditional treatment options, we don't have phase 3 trials apart for the JAK inhibitors and pomalidomide as an immune modulator. Still, they could be useful for certain subgroups of patients. We know, for example, that ESAs are not likely to help patients if the EPO level is above 500 units per liter, steroid side effects. On the bottom line, I think the mainstay and the standard of treatment today are JAK inhibitors. And we would like to look at their impact on symptoms, on survival, generally in patients with myelofibrosis. But I think a closer look, particularly in patients with anemia and thrombocytopenia, is worth doing. And with this, I would like to start again with the first question that was pre-canvassed from an audience. How does JAK inhibition impact outcome for patients with myelofibrosis, particularly for patients with anemia and thrombocytopenia? And I think outcome is now symptoms and quality of life.
Those JAK inhibitors have a profound impact on quality of life and symptoms of patients. For example, ruxolitinib was tested in 2 large phase 3 trials, COMFORT-1 in the US, COMFORT-2 in Europe mostly, and showed a huge benefit in terms of symptoms reduction and spleen size reduction. So the reduction of the spleen volume has become a clear marker of efficacy of all the drugs that were tested after that based on this, let's say, first study of ruxolitinib. The second, fedratinib, that is now available in France and in Europe in clinical practice, also showed very nice results in terms of spleen volume reduction and symptom reduction in large clinical studies called Jakarta 1 and Jakarta 2. And these 2 drugs have clearly changed the life of our patients by improving their symptoms, reducing the so-called constitutional symptoms, pruritus also, and reducing the spleen volume. However, anemia and thrombocytopenia are on-target adverse events of these drugs that may sometimes limit their use or their efficacy, because if you induce too much anemia, then you will have to decrease the dose of ruxolitinib in particular, and then you may lose the benefits in terms of quality of life and symptoms.
And I fully agree. And in addition to Rux and fedratinib, now our treatment landscape has been enriched in Europe, at least for momelotinib, and in the United States, even pacritinib. So, Professor Vannucchi, what is your impression about the impact of these 2 newer JAK inhibitors on patients with myelofibrosis?
Well, both 2 drugs, momelotinib and pacritinib, that is not approved in Europe, as you mentioned, show the same impact as described by Professor Kiladjian in terms of spleen volume reduction and improvement of quality of life in patients with myelofibrosis. It should be mentioned that these drugs have been used particularly in patients who are cytopenic, and momelotinib is approved for patients with moderate to severe anemia, while pacritinib has been used especially in patients with thrombocytopenia. And in the studies with both momelotinib and pacritinib, the drugs proved to be effective in terms of spleen volume reduction and improvement of quality of life. And at the same time, they also showed activity in improvement anemia, reducing the proportion and the intensity of transfusion dependence in patients who are transfusion dependent. I would also like to mention that these are JAK2 and JAK1 inhibitors, but they also have a unique activity against the activin receptor type 1, and this is probably the way they function on anemia through regulation of hepcidin pathway. That is unique to these drugs, particularly to momelotinib, unlike ruxolitinib and fedratinib.
In addition to the improvement of the quality of life, I think we have some data to the survival, particularly in younger patients. I think this becomes more and more important. So maybe to go back to the older JAK inhibitors, Professor Kiladjian, ruxolitinib and fedratinib and their impact on survival.
Well, when the first studies have started with ruxolitinib, we didn't expect such an efficacy. And indeed, in the COMFORT study, for example, overall survival was not a primary objective of the study because we had no idea that could be the case. But with a post-hoc analysis that has grouped both COMFORT 1 and COMFORT 2, we were pleased and surprised to see that there was a clear benefit in terms of survival in patients receiving this JAK inhibitor. And indeed, the same was shown after that with other inhibitors. And we have now real-world studies that confirm these findings. For example, for ruxolitinib, we have some studies showing that the median overall survival from ruxolitinib initiation in patients with intermediate and high-risk disease was about 44 months. And in patients with, this was true, but less, let's say, in patients who have cytopenia, in particular for those who are thrombocytopenic. At baseline, this life expectancy was lower, 42 months approximately, compared to 63 months in patients with elevated platelet counts. Similar findings with fedratinib, with a median overall survival of around 30 months after initiation of the treatment in real-world studies. And again, an estimated progression-free survival of about 72% at 12 months, which is quite nice.
Yes, definitely. Although no primary endpoint survival in any of these trials, but I think we all agree that there is a survival benefit. For momelotinib and pacritinib, the follow-up data are definitely less. But Professor Vannucchi, what is your idea about survival benefit of the newer JAK inhibitors?
Of course, as you mentioned, this follow-up is shorter, and so it's really difficult to have an opinion, a firm opinion about the impact on the survival of these two drugs. However, we have the first real-world evidences that this drug, even in real-world experience, are not only well tolerated and effective, but probably they are associated with improve outcome of patients with myelofibrosis. For example, as regard momelotinib, it has been presented a retrospective study including about 85 patients from the United Kingdom, and most of these patients were actually intermediate on and high risk myelofibrosis, and at 12 months more than 82% of these patients were still alive. That, considering the high risk population, is something that makes a lot of sense. And also for pacritinib, there is some real world evidence. This, of course, comes from the United States. More than 140 patients were included in this real world study. About 1/3 of these patients had thrombocytopenia, and more than 30% were anemic. And at 1 year, the overall survival probability was about 70%. And this was really a high risk population of anemic and thrombocytopenic patients. So again, something that makes sense, and hopefully this will be confirmed with longer follow-up for both drugs.
I think I fully agree. And, maybe making patients transfusion independent might have even a much bigger impact on survival than we realize today. Well, maybe just again a look to ruxolitinib and thrombocytopenia, fedratinib thrombocytopenia. Professor Kiladjian, what are your thoughts? Could we use ruxolitinib or fedratinib in anemic patients or thrombocytopenic patients?
Well, indeed, yes. In terms of anemia, there's no clear limitation, obviously, because you can still transfuse patients. So if you need to use these first, let's say, JAK inhibitors, you may. It's advised to start at lower dose for ruxolitinib, for example, for patients who are anemic compared to those who are not, less than 10 grams of hemoglobin. But you know that you will necessarily, obviously, worsen this anemia, at least for the first months of treatment. Regarding thrombocytopenia, it's the same. We have about 50% of thrombocytopenia worsening with these drugs, and we know that it's not really advised to start ruxolitinib or fedratinib in patients with less than 50,000 platelets. With momelotinib, we have a lower threshold, about down to 25,000 platelets, but still, for thrombocytopenic, we are waiting for pacritinib that will focus especially on this population of patients.
And again, back to Professor Vannucchi, any thoughts particularly for patients with severe thrombocytopenia and transfusion-dependent anemia?
Yes, of course, these drugs were are specifically approved and were used largely in patients who were anemic or and thrombocytopenic. And as regards to thrombocytopenia, that is one of the main limitations in the use, for example, of ruxolitinib. We know from all the trials that you mentioned with momelotinib that patients with even up to 25,000 platelets were successfully treated with the drug without any significant impact on the dose of the drug, and they showed responses in terms of spleen volume reduction and quality of life that were comparable to patients with who were not thrombocytopenic. And the same, of course, in patients with anemia. Again, this could be treated with conventional doses of the drug, and they were successful in reducing the spleen and improving symptoms.
What factors guide you for the selection of a particular JAK inhibitor in a particular patient?
These drugs do not aim to cure the disease, so we still have to focus on the main, for me, the main complaint of the patient. Is it the spleen? Is it the constitutional symptoms, the night sweat? Is it pruritus? And we know that these drugs have a different efficacy on all these particular symptoms. Ruxolitinib, for example, is very good for pruritus. If it's the main question of the patient, the main problem, then I would prefer this one. Balancing between the main benefit you expect for your patients and the potential risk may help to define the best profile. And obviously for cytopenic patients, we have now these two drugs. We will have soon these two drugs that focus on this particular population.
Fully agree. Professor Vannucchi, are we now at the end of our treatment landscape, or are there any other treatments in development for patients with myelofibrosis?
Well, the field is moving. We have now choices, as mentioned by Professor Kiladjian, but we aim to get more in terms of control of the disease. And so there are several trials that use additional drugs, additional targeted pathways, usually in combination with ruxolitinib, fedratinib, and more recently also momelotinib. And so we have trials with drugs that, for example, are BET inhibitors that are in an advanced stage of development, or other drugs such as, for example, imetelstat that is an inhibitor of telomerases, and other drugs in addition. So it's a moving field. We are collecting data, and we also look not only at improved quality of life, spleen volume reduction, but especially to prolonged survival, and also to collect evidence about biomarkers of the disease.
Yeah, I think it is an exciting time, particularly for our patients, moving forward to improve outcome. Now I would like to talk about how to maximize benefits for patients with myelofibrosis regarding different treatments available today. We have multiple factors we have to consider when deciding to treat a patient with a JAK inhibitor. We have often elderly patients, a lot of comorbidities. We know about the adverse events of certain JAK inhibitors, particularly anemia and thrombocytopenia, particularly in anemic thrombocytopenic myelofibrosis patients. And we have patients' wishes, we have patients' insights, patients' education. So we have questions when and how to start the treatment, what and when should I monitor, and how could I switch from one treatment to another? And what about the role of clinical trials? So there are still a lot of aspects, and I would like to discuss them together with my esteemed faculty. Professor Vannucchi, I would like to start with you. How would you identify a patient profile for a certain JAK inhibitor from all the available repertoire we have?
As you very nicely pointed out, Professor Al-Ali, we have several issues for the patient that we should keep into account when thinking about what of the three JAK inhibitors that are now approved in Europe is best for the patient. Of course, there is no strict rule, and we have to take into an account a lot of variables. I made just a couple of examples. For example, if a patient presents with anemia, I'd say moderate to severe anemia, maybe that the first choice for this patient is a JAK inhibitor that, while maintaining activity on the spleen volume reduction, if the patient has symptomatic splenomegaly, would save red blood cells and would prevent a worsening of anemia and eventually reduce transfusion dependency. Well, I would favor momelotinib that has been shown to be active in this kind of patients. If the same patient presents with huge splenomegaly, huge symptomatic splenomegaly, maybe that I would favor ruxolitinib or fedratinib. But let me make another examples on the opposite side. For example, a young patient who is candidate and is being prepared for stem cell transplantation and has splenomegaly, well, I would prefer ruxolitinib, even if we have to pay something, let's say, in terms of red blood cell reduction anemia. It's a short period of time. I would maximize the dose and keep the patient, bridge the patient to stem cell transplantation. So there are several different clinical aspects and situations that are to be considered.
Definitely, definitely. And the more drugs, the more challenging and the weighing risk benefit becomes. And I always say this is good to be a doctor and not a machine. Professor Kiladjian, how do we monitor response? How do you monitor clinical response? And when do you consider a patient refractory or a patient that lost response to one JAK inhibitor and you consider switching?
For the following of the patients and evaluation of response, I think we need some time, not too much, but this should be evaluated, let's say, between 3 and 6 months after starting, in my opinion, one of these JAK inhibitors. And of course, you have to collect objective measures for assessing the response. You know that in clinical trials, we determine the spleen volume by MRI. Obviously, we don't do that in clinical practice. And let's say that just a good measurement of the spleen by palpation, but not using only fingers as an endpoint, but measuring tape with centimeters is important to follow. Sometimes I do an echography at the beginning before starting treatment to have an objective measure of the spleen size, and repeat that after 3 and 6 months to be sure that we have a response or not. Also, the symptoms should be measured, if possible, in an objective way using a questionnaire. I know that few of my colleagues use these MPN symptoms assessment forms, the MPN SAF, but clearly it's a very useful tool to see the evolution of the symptoms over time in a patient. It doesn't take time during the consultation. Patient can do that in the waiting room and bring it with them, and it's really very helpful. Of course, we had to follow blood counts also for toxicity mainly and tolerance. We discussed a lot of anemia and thrombocytopenia, but we have to take this into consideration. And then for switching, obviously, if there's an intolerance issue, either through severe thrombocytopenia or clinical intolerance, it's a reason to switch. Otherwise, it's difficult because we don't have a clear definition of suboptimal response or failure. But I think that all of us as a clinician, by discussion with the patient and collecting these objective measures of the spleen size and the symptoms, help us to see if the patient is happy or not. He's indeed the first person implicated in that. And so he will tell us if he's satisfied with the response or not. And we may, with these objective measures, then switch to another drug.
I fully agree. Unlike CML, we don't have these clear-cut guidelines and when to know failure, refractory. And so the experience of a physician remains very, very important, as you said, together with the patient. Professor Vannucchi, how do you do it in your clinical practice? Monitor and manage potential side effects arising under a particular JAK inhibitor? Do you have special warnings or considerations?
Yes, so there are in the sense that we know from huge experience with ruxolitinib, fedratinib, but also with momelotinib, which are the most common expected side effects. Apart for anemia and thrombocytopenia that are induced by the drugs, and as mentioned by Professor Kiladjian, require strict control of blood values, particularly thrombocytopenia that is also impacting on the dose of ruxo that we can use. We know, for example, that ruxolitinib is associated with an increased risk of infections. This means, for example, that we can use vaccination to prepare the patient before starting the treatment. We have to screen for occult viral infections, tuberculosis, and so be sure that there is no baseline risk factor before starting this treatment. And another common side effects of ruxolitinib is represented by development of skin cancers. And so some patients with a history of skin cancers or who are very exposed to sun because of working duties and so on, well, this may be at risk of the skin cancers and might be a reason to decide not to use, for example, ruxolitinib in these patients. We know, for example, that for patients who we decide to treat with fedratinib, we have to check for the risk of encephalopathy, and so we have to measure the blood level of thiamine and eventually supply the vitamin. There are also some GI effects that are most common with fedratinib than with ruxo and even with momelotinib, and so prophylactic measures might be used in these patients, especially in the first weeks of treatment. And then, of course, there's a lot of open issues for the long-term immunosuppression of these agents, but I also would say that we need more data about the impact on these drugs on prevention of disease evolution and also of the most common cardiovascular events that these patients might suffer from.
Yes, there are a lot of things to be considered. And yeah, we don't have to stop learning and observing our patients. And I think it is so important to, integrate patients, empower patients for their discussion. Professor Kiladjian, how effective is this patient education and support? Does it have an impact, a positive impact on patient management over the long run?
No, I completely agree with you. It's key. The patient education, I think, in this disease is key because they have a potentially very dangerous disease with severe complication. The treatments we give them have the limitations that Professor Vannucchi just outlined. So if they don't know that there's this risk of zoster reactivation, for example, with ruxolitinib, they will not take the treatment efficiently at that time. And it's also key to maintain the treatment over time and have these benefits we have discussed in terms of overall survival, etc. So informing the patients, we know that we have two profiles of patients. Those who are very educated come with a lot of, they've seen everything on internet, etc. And others who don't want to hear anything and are not involved. So we have to find a way to balance that. And I think patient support group are very important to help them and give them another view compared to the doctor's view. Another, having a view of other patients may change their view on their disease and help them to better manage their treatment and the potential complication or side effects. And also we can now rely on specialized hematology nurses that also can help us to educate the patients or answer questions between two consultations. So I think all this support and education of patients is really key in a disease such as myelofibrosis to have the better outcome and the best possible use of the different drugs we have today.
Absolutely agree. I always say an educated patient is the best guarantee for the optimal outcome. And for this, I would like to thank you very, very much. Thank you.